Hi, my name is Dr. Robert Rutledge, and I'm giving a presentation at the International Federation of Surgery of Obesity European Conference in Barcelona in April 2012. And we're waiting for the beginning of the session, but in preparation, I thought we'd go through a brief talk on the mini-gastric bypass. First of all, I need to give thanks to my host. This is Dr. Kular from BJ, India, and I want to express my profound thanks. Dr. Kular has been kind enough to host me as I visited him in his wonderful hospital in India, and I got a chance to observe him and participate in surgery with Dr. Kular, and I can say he's a wonderful surgeon, and it was a great honor and a pleasure to work with him. I might give you a little bit about my background. I'm very proud to say that I was taught and educated by Dr. Lester Dragstad. Dr. Dragstad, as you may remember, is the physiologist and subsequent surgeon who identified the purpose of the vagus nerve in the stomach and invented what was at the time the highly controversial vagotomy and pyloroplasty. And as my teacher, I think I adopted a lot of his approach to surgery, particularly his fact of being an iconoclast in the area of surgery. I had 2 years of cardiac surgery at the National Institutes of Health and spent 20 years as a professor of surgery at the University of North Carolina, and I'm the author of 93 papers. My specialty was trauma and critical care, medical informatics, and bariatric surgery. But interestingly, since I am old, I am familiar with peptic ulcer surgery when it was common. Prior to the invention of the H2 blockers, cimetidine, Tagamet, Zantac, and those drugs, peptic ulcer disease was a common surgical illness leading to surgery for peptic ulcer disease to be one of the fourth most common surgeries performed in the United States. The types of operations are interesting in that it included the vagotomy and pyloroplasty, which was, when it was proposed by Dr. Dragstad, very controversial, and the very common antrectomy and Bill Roth too. And so, as I say, I'm old enough, and my gray hair demonstrates that I'm old enough to remember gastric surgery before H2 blockers. And that included a very common surgery which we knew well and managed all the time, and that is the antrectomy and Bill Roth 2, which was a good operation. Not perfect, but a good operation. Also, because of my age, I've been in bariatric surgery for over 33 years now. My initial practice was performing open, Roux-en-Y, and the now discredited vertical banded gastroplasty. In 1997, I was one of the first surgeons to do laparoscopic Roux-en-Y after observing Michel Gagné at the Cleveland Clinic. And since that time, over the past 15 years, I've done over 6,000 mini-gastric bypasses. We're going to be talking today at this conference about the mini-gastric bypass, and we're going to be arguing, I think, pretty much to a man and a woman that we are of the opinion that the mini-gastric bypass is really a superb weight loss surgery. That our belief is that as far as the treatment of obesity, there's really not any other operation that is its equal. And while we argue that the operation itself is an attractive one, a good one, and I would say we think the best choice for our patients, we also include a warning, a caveat. We honestly believe that there are some important tricks and traps to doing the MGB and doing it well. I'm happy to say that we offer a program to educate people in the performance of the MGB. I have been very flattered to be a visiting professor in Paris, in Turkey, Austria, India, and I've also had the good fortune to visit the Czech Republic, Italy, Germany, and have upcoming visits to the United Kingdom and other countries. My goal and my wish is that if people are interested in adopting the mini-gastric bypass, is that you adopt it in a safe fashion. We'd like to provide warning, advice, tips, pointers, so that superb surgeons can use the techniques that we have come across in a safe way for their patients. I believe Dr. Kular in India is going to be providing an actual didactic session along with hands-on, so that surgeons who have an interest can actually scrub in on cases and participate in that. And so if you're interested, don't hesitate to contact him. And now I'd like to kind of change topics for a moment and tell you that you and I and physicians and human beings in general are seriously flawed. Well, that's not new news. But recent research has shown just how bad humans are at decision making. And I think that's important to discuss because we have to make decisions all the time for our patients. And particularly, what I'll be talking about today is the important decision about choosing weight loss surgery for your patient. So I'd like to just very briefly, only take 2 seconds or so, to go over the fact that lots of recent research demonstrates some very serious flaws in human decision making. And when I mention these, I think some of them will be clear to you. So as I say, there's a variety of human research which suggests the brain is often a bad decision maker. So as an example, the brain has been shown, humans have been shown to exaggerate rare events. And they downplay common events. It's been shown that humans underestimate tasks that they have chosen, and they overrate risks that are beyond their control, so the car and the airplane. We also overestimate risks when we talk about them. So irrational and illogical thinking is part of us, and that's important because we're scientists, we're doctors. We carry people's lives in our decisions. And so there's some now well understood biases. For example, the confirmation bias. Confirmation bias means that if we hear information, we tend to listen and retain information that confirms what we already believe. We all have understood herd behavior. That's where we have groupthink. If several people agree, then we all tend to go along with that. We now understand more about what's called the reptilian brain, the amygdala, which is impulsive and primitive and triggers an emotional response at times. So fear and confusion often can mislead us. When we have taken functional MRIs of human beings making decisions, what we found is if you look at the frontal cortex, that lights up when we do analytical thinking, math problems, things like that. On the other hand, when we make snap decisions, emotional decisions, that base, the amygdala, tends to light up, and it interferes with analytical decision making. So we have kind of two systems in the brain, the rational, logical, but also the amygdala, which is more emotional. Again, confirmation bias is very important in the case of choosing a weight loss surgery, because when you have a confirmation bias, even when you get evidence to the contrary of what you believe, it actually strengthens that belief. Now let me say that again, because it doesn't make any sense. You believe A, you hear the opposite of A, it makes humans believe more strongly in A. Overconfidence in present beliefs has been shown. So if you believe something, you tend to be more confident than you really should be. And this kind of poor decision making is much more common in organizations, military, political, and social groups. So the reptilian brain affects decision making, and it gives us errors in risk assessment. For example, let's think of death that could occur in an airplane crash or death that might face you in a car crash. The rates of death are much higher in a car crash, yet we fear the airplane crash more. Let's think about cancer. Cancer has an inherent reptilian primitive fear associated with it in human beings. And so let's imagine you had a risk of 1 in 1,000 patients over 20 years of getting gastric cancer. People might grade that higher than they would, say, from bowel obstruction from an internal hernia, which might occur in up to 16% of Roux-en-Y bypass patients. Also, there's the history of surgery. We have a history of making mistakes. Look at Lister. American surgeons delayed the adoption of hand washing and antisepsis for 10 years. This is a very famous painting of Dr. Gross in Gross Clinic. In 1875, he's operated. That's a patient being operated on, bare hands, no antisepsis, no mask, no gloves, and Lister had published his papers on antisepsis in 1867. So humans make errors, surgeons make errors, and so it's appropriate for us to reconsider in our minds how we make decisions. And I'm going to suggest in this preparatory talk while we wait to start the meeting that there's a methodology that might help us avoid some of these internal biases. And that's basically what's called the PROACT methodology. You identify a problem, you name the objectives, you list the alternatives, you analytically list the consequences and trade-offs. And this has been shown to help, not perfectly, but to help make decisions a little bit more rationally. And I'm going to go through that very briefly today. Okay, our problem is simple for today, the PROACT methodology we're going to be using. It's obesity. And going along with that, besides obesity as a problem, there's another major issue, and that is the history of failure of weight loss surgery. And we can see that in our meeting here today, all the various sessions talking about failed weight loss surgery. And so this is my biased assessment. Jejunal ileal bypass, failure. Vertical banded gastroplasty. Still a few people doing it, but I would say failure. And it's one that I did very many of. Lap band, again, this is a biased opinion. My experience when I had the chance to visit India, it was a very popular surgery. Many people did lap band. And now, no one? At least in India, I would say it's being shown. My bias was that the lap band was a restrictive procedure on the stomach. I would say, Dr. Shashank, in India, the lap band's a failure? Yes? Around the world, not yet. Not everyone believes it's a failure yet, but I believe lap band, in my opinion, a failure. Roux-en-Y bypass, biliopancreatic diversion. Recently, an article, Controlled Prospective Trial. Dr. Livingston did a nice commentary. My bias is you could see those in a negative light. Sleeve is now the most popular new surgery. I think most people would agree. Leak rates, 60 to 80% reflux at 5 or 8 years, irreversible because you can't get out of it. And weight regain are all important issues. My bias is if we look at plication, sleeve, vertical banded gastroplasty, band, they're all attacks on the stomach. They're all restrictive variations. And my bias is they are all probably going to be failures. But that's my opinion. Now, what's our objectives? If we have a problem, we've identified the problem, we have obesity as an epidemic, the other weight loss surgeries have failed, then we're going to set up objectives. And I'm going to go through this quickly, I apologize, but we can go into more detail if there are questions later. What is it we want? Well, I've created a 30-point success criteria. Low risk, major weight loss, easily performed, change in behavior, minimal retching and vomiting, few adhesions. And I might interrupt and say, you don't need to take pictures of these. These are all online. This slide series is all online. You're more than welcome to it. If you email me, I'll send you a copy in PowerPoint. So, low failure rate, low cost, low risk of ulcer, fat malabsorption, etc., etc. And I made 30 success criteria. And I'm going to go through and give you my opinion on how the various operations stack up. But for my purposes, again, I'm going to go through them quickly because we have other things to get underway today. And I'm going to look at the Roux-en-Y, the sleeve, the band, and the MGB. Just a brief history. The mini-gastric bypass has been done from 1997 to 2012. There are over 6,000 patients in my personal series who now have surgeons who've contacted me from all around the world that are doing the MGB. We have over 15-year data from my series, 10-year data plus from Taiwan, randomized prospective trials. Basically, it includes two very well-researched components. A vertical gastric tube, it's got a sleeve. It's part of the sleeve. It's a sleeve from 1997. We have been doing sleeves in the MGB for 15 years. And it turns out, I also know how sleeves do. And they don't do very well. Because we've done some patients where we could not do the gastrojejunostomy, and the sleeve portion of an MGB is about half as effective as the MGB itself. And then the second component is the bypass portion. That's the Billroth 2 gastrojejunostomy. And this is where the Billroth 2, the gastrojejunostomy, the mini-gastric bypass has kind of gotten its bad reputation because it, like the old loop, is a Billroth 2. And we remember Dr. Mason did a loop gastric bypass, but he put the loop adjacent to the esophagus, which we know, or he should have known, is an untenable anatomic reconstruction. So this is the mini-gastric bypass, and we should go over a few things. One is that the mini-gastric bypass is being done very commonly. Just this past month, a surgeon from Korea published a series of 300 laparoscopic Billroth 2 reconstructions of gastric cancer patients. And basically he has a nice video and photographs of his performance of the surgery, and it looks like he's doing an MGB. He does a distal gastrectomy and a Billroth 2, and he describes it as short, simple, safer than the other types of operations, and he recommends it. And we can say that in the United States in 2007, over 16,000 Billroth 2s were done. They're done for trauma and for ulcers, cancer of the stomach, etc. All right, here's our criteria. We're using this Billroth 2. We want to talk about these criteria. And again, I apologize because of the purpose of this talk. I'm going to go through this rather quickly. And if you look, just look on the right side. If you look at all 30 success criteria, the mini-gastric bypass is excellent in all but the risk of marginal ulcer. And there it is equal to the Roux-en-Y. So what we would argue here, and I'm not going to make this the focus of my talk, and we can go into each of the 30 success criteria, the MGB is by far and away the best choice for weight loss surgery. It's more effective, it has better weight loss, it has a better revision technique, and so for all these reasons, we think it's the best choice. But there is this persistent fear of gastric cancer and bile reflux. And so that's what I really want to talk about for just a few minutes to basically put that to rest. Now, first of all, again, in addition to humans having a relatively bad history of making good decisions, I'd also like to point out that there's a lot of medical literature that shows that doctors are not very good at reading the medical literature. And this area in particular, the area of looking at the risk of gastric cancer after Billroth 2, is a very impressive one because of the really poor literature on this topic where surgeons have not done a good job of reading the medical literature. And here's an example. This was published by Collins et al. In the Archives of Surgery in 2007. And he said, here's a quote, "The long-term effects of chronic alkaline reflux in the stomach after a Billroth 2 gastrojejunostomy are unknown." Well, that's absurd. We've been doing Billroth 2s since Billroth did it right after the Civil War. We have over 100 years follow-up and over 1,450 papers on the Billroth 2 and its outcomes. So we know absolutely what the effects are. And let me remind you of that medical literature. So we're going to be talking now about the risk of gastric cancer. Do you fear gastric cancer after an MGB? Is it something to be concerned about? Let me first mention, you should know that gastric cancer is one of the biggest success areas in the world of cancer. It's declining fourfold since 1930 in the United States. In other words, gastric cancer is going away. In addition, it's very clear that although some bariatric surgeons fear the Billroth tube, the cancer surgeons routinely choose it, as I reported in that article from Korea, but there are hundreds of others. The Billroth tube is being done commonly for general surgical procedures. It's only in the area of bariatric surgery where surgeons with inadequate recollection of the past are fearing the Billroth tube. But let's go into a little bit more detail and see what is bothering surgeons about the Billroth tube. What is the magnitude of the problem of gastric cancer after Billroth tube? Well, let's look at a couple of studies as an example. This is the Mayo Clinic. 300 patients who had a Billroth tube followed for a quarter of a century, 25 years. 5,000 people. They found 2 cancers in 5,000 person years of follow-up. And those 2 cancers were lower than what was predicted in the general population. 338 patients, 25 years, 5,000 years of follow-up, 2 cancers. This was reported in 1983, and since then, the rate of gastric cancer has declined over 2-fold. So we're probably talking about a 5,000 person year history of Billroth tubes, and seeing 1 patient potentially develop gastric cancer, and that is the same rate that is seen in the general population in this group in the area around the Mayo Clinic in America. Okay, now there has been a very nice meta-analysis. They looked at 12 studies of Billroth tubes and whether Billroth tube was associated with cancer. Okay? 7 studies showed a small increase in risk. 5, like the last one I showed you, so no increase in risk. But there's a flaw in these studies. Do you know what it is? Patients who had Billroth tube in these studies had it for ulcer disease. And ulcers increase the risk of gastric cancer. Recall that we now know that both ulcer disease and gastric cancer have the same underlying etiology, Helicobacter pylori. So let's look at the data on ulcers. If you look at 3,000 gastric cancer patients compared to 89,000 controls, ulcers increase the risk of gastric cancer, about 1.5 relative risk ratio. This is exactly the same as those few studies that showed an increased risk with Billroth tube. So many studies confirm these findings. Ulcers increase the risk of gastric cancer, and ulcers and gastric cancer have a common etiology, H. pylori. Again, bariatric surgeons fear the Billroth tube. What about our friends, the gastroenterologists? There are hundreds of thousands, potentially even 1 million more patients who've had a Billroth tube. What do gastroenterologists recommend for follow-up? If cancer is a danger in those patients, if it's a reasonable risk, shouldn't the gastroenterologist be recommended 10-year screening or 15-year screening or something like that? But there's not. For example, in a study to answer this question, a gastroenterologist looked at 63,000 patient years of follow-up and found 23 gastric cancers, which was equal to or lower than predicted in the general population. In another study, a follow-up 1,000 patients for 22 to 30 years, 196 endoscopies, and found no cancers with biopsy, and their quote in the British Journal of Surgery in 1983 said, endoscopic screening is not indicated in a Billroth tube. It'd be unrewarding. And again, 83, now, 30 years later, the rate of gastric cancer has declined tremendously since this study reported those results. Stomach cancer in India, it's a very low cause of cancer. And so what does cause gastric cancer? That may help you in finally putting this concern of the Billroth tube to risk. It's your diet. It's fried, salted, smoked, or preserved foods, foods that contain nitrates, and diets that are high in healthy fruits and vegetables, diets that don't use salted and preserved foods protect against gastric cancer, and smoking and alcohol is increased the risk. And there are new studies, as you probably well know, H. pylori causes gastric cancer. Okay, diet. Avoid alcohol, tobacco, processed meats, and processed foods. The biggest intervention to prevent gastric cancer has been the refrigerator. As countries have gained the opportunity to avoid processed meats, gastric cancer is declining. Also, the treatment of H. pylori. There are some prospective studies suggesting that treatment of H. pylori can prevent this illness. Also, eat fruits and vegetables. If you're worried about gastric cancer, you can drink some green tea and eat a healthy diet. But you don't have to have a Roux-en-Y. Which is more dangerous? Now this is I want to go over one more thing. It's called clinical significance, statistical significance. All those studies I showed, thousands of patients' years in follow-up, there's a slight increase in risk in Billroth-2 gastric cancer. The rates of gastric cancer in those studies is lower than the risk reported by eating hot dogs because of their associated risk of containing nitrates. All right, so what I've tried to say today is, look, gastric cancer is declining rapidly by over 50%. Gastric cancer is primarily caused by environmental factors, and it's easily prevented. Eat a healthy diet, avoid alcohol and cigarettes, treat H. pylori if you're worried about it. There are straightforward things to do if you're worried about it. There are some studies which lead our colleagues to sometimes say Billroth-2 is associated with gastric cancer. That is statistically significant in some cases. It's probably not clinically significant. And if you're worried, there are things to do. Remember that Billroth-2's in those studies was done for ulcers, and ulcers are caused by H. pylori, and H. pylori we now know causes gastric cancer. And there are many large studies of thousands of Billroth-2 patients that never sustained any increased risk of gastric cancer. Endoscopic screening of Billroth-2s is not recommended. What does this tell us? That our colleagues think there's no significant increased risk that would justify screening follow-up with endoscopy, because the incidence of gastric cancer is at, equal, or below the risk in the general population. General and trauma surgeons routinely use the Billroth-2. In 2007, 16,000 times. So to finish my talk, I'll say the Billroth-2 and the Mini-Gastric bypass, I believe, are excellent and safe and effective. The fear of gastric cancer, if you have it, there's some things you can do. Tell your patient not to drink alcohol, smoke cigarettes, treat H. pylori, eat fruits and vegetables. But a Billroth-2 probably makes no difference. A rational review of the data shows fear of gastric cancer and bile reflux is just not a rational review of the medical literature. Again, gastric cancer is declining. Gastric cancer is environmentally caused. Some studies do show an increased risk, probably from ulcers and H. pylori. Many large studies show no increased risk. Endoscopic screening is not recommended. General and trauma surgeons use the Billroth-2. Fear of gastric cancer, easy. Avoid alcohol, tobacco, processed meats, treat H. pylori, eat fruits and vegetables. Billroth-2 probably makes no difference. A Billroth-2 probably makes no difference. And thank you very much. Now we have our presenter.